Hello, welcome to another session of Zooming Through ID. I'm Dr. Gopal, an infectious disease physician, been practicing in South Florida for 20 years. I trained at Duke University. I am the medical director here at Broward facility for infection control, and I chair antibiotic stewardship. I am a faculty for internal medicine and I am the APD for Infectious Disease Fellowship here. This session, Zooming Through ID, this is designed as a short, focused teaching forum where the residents and fellows take ownership of learning. Each presenter um, selects a topic, either assigned to them or they pick a topic of interest, and they do literature review and present in this session here, and they will teach us what they have learned. This is not just presenting the facts, but they have to be thinking critically. Why is this topic important? How is it relevant for real patients? And what can you take from here to the clinics or bedside to the hospital patients that you see? So today, the presenter is Anjo Chaco, and he is going to present a very interesting topic, monkeypox. And he has put in a lot of effort. And I will let you introduce yourself. And yeah.
Thank you, Dr.
And
Gopal,
he
for that.
rounded with me, and he was very nice, and he had great bedside manners, and very sincere, hardworking, and looking forward to your presentation.
Thank you so much, Dr. Gopal. My name is Andrew Chaco. I'm a third year resident now at Broward Health North. I'm originally from New Jersey, moved down here for residency. My family's now in Tampa. Currently, next, I'm going to go do fellowship at University of Miami for nephrology. So looking forward to that.
Yeah, congratulations on that. Yeah. So
So I will start sharing the PowerPoint. Are you able to see that, Dr. Gopal?
perfect. Yeah, looks
Uh,
perfect.
Okay,
Yep.
so today we're going to be speaking about monkeypox. So recently, there has been, in the past couple of years, there has been an outbreak. So it is important for us as clinicians to recognize and diagnose this disease. So this is one of the reasons why we had come up to choosing this topic. Um, Sorry, it's okay. So the most of the information that I've obtained for this presentation was published from this article in the IDSA. It gives us a review on to healthcare professionals on how to background of this virus and also about a background of how to recognize and diagnose and the management as well. So going into the background of this, it is a zoonotic orthopox virus. It was first identified in 1958 in research with monkeys, with the first human case reported in 1970 in the Democratic Republic of Congo. For decades, cases were largely confined to Central and West Africa. However, with the 2022 outbreak, there was involved in like transmission in non-endemic regions as well, including the US and Europe. So one major key concern was that after the eradication of smallpox and cessation of routine smallpox vaccination, there was population level immunity to orthopox viruses that declined significantly. So this like created an ecological niche that monkeypox may partially fill. So contributing factors to this were deforestation, increased human-animal contact, urbanization, and globalization. So just a little bit about what this virus is. It belongs to the Poxviridae family with the genus of orthopox viruses. Some other common orthopox viruses that we are aware of are the variola, most commonly known as the smallpox. We have the cowpox and the vaccinia. So orthopox viruses are immunologically cross-reactive, which is why smallpox vaccination provides cross protection. The virus has multiple suspected animal reservoirs, likely small mammals such as rodents, although the definitive reservoir has not been confirmed. So it is a large double-stranded DNA virus that replicates entirely in the cytoplasm. Unlike most DNA viruses, it has two infections form. The first form is the intracellular mature virion and the extracellular enveloped virion. It's a large genome. It encodes proteins that interfere with host immune responses, contributing to like immune evasion and pathogenicity. So, smallpox demonstrated how severe orthopox viruses can be. With smallpox vaccination that was discontinued more than 40 years ago, immunity has waned globally. There is a concern about how the viral evolution towards greater transmissibility can be. So, for clinicians, it's understanding how the transition, the dynamics, and recognizing early disease is critical for containment. So the endemic regions, as we talked about before, are mostly in Africa, located in Nigeria, Cameroon, Democratic Republic of Cameroon, and Central African Republic. Prior to this, cases outside Africa were typically travel related or due to imported animals. The first time in 2022 was when we started first seeing a widespread of this transmission across multiple continents. So there are two major clades. The first clade is the Congo Basin clade, which has a higher transmissibility and mortality. And the second clade is the West African clade, which is a milder disease. The 2022 outbreak was due to the West African clade, and transmission occurs through direct skin-to-skin contact, respiratory droplets during close contact, and fomites and animal exposure. In 2022, intimate and sexual contact emerged as a major transmission route. So this is just a diagram or picture like emphasizing how this viruses can be transmitted. So getting into the clinical presentation, how this disease usually presents, its risk factor. Um, the classic presentation includes a prodrome. You get fever, malaise, headache, and lymphadenopathy. And then you get a rash, usually beginning in the face and then spreads down to your extremities. And the way how this lesion progresses is usually as a macule, then to a papule, then to a vesicle, leading to a pustule, and then to scabbing. So patients remain infectious until all the lesions have crusted and re-epithelialized. So complications can include secondary bacterial superinfections, encephalitis, pneumonitis, and keratitis. So the 2022 outbreak was the first time we saw how this presentation differed. So lesions were mostly localized to your genital perianal regions, and there were fewer total lesions than normal. There was an asynchronous development, and there was mild or absent prodromes. And then for this virus, the lymphadenopathy remains a distinguishing feature compared to smallpoxes. And differential diagnosis, while we see such rashes, we want to include like HSV, syphilis, varicella, impetigo as well. So this is also a diagram here showing how the presentation of this disease happens. Here we are showing how this disease progresses as the rash evolves throughout its course. So in the first day, it comes as a macule. Then through the second and third days, you get a papule to a vesicule. Towards the end of the week, you see a pustule, and then towards A week to 2 weeks later, you see it scabbing. And these are some other images that I got from the CDC website. It just emphasizes how these lesions present. Most of the time, they are firm and have umbilication. They typically develop at the same time and then evolve together on any given part of the body. And this is some more images collected from the DermNet as well, just showing how these lesions can present throughout the body. So diagnosis is critical. We need to maintain high clinical suspicion when we see rashes in patients, just especially when this has been most in the recent years, especially with the atypical 2022 presentations. We want to get a thorough history, including travel, sexual exposure, close contacts, do a full skin and mucosal examination. The gold standard to diagnosing is doing a PCR from lesion swabs. You should do testing, should involve multiple lesions when possible, and coordination with the public health authorities is also critical to do. So management. So management is mainly supportive care, which includes hydration, pain control, and treatment for secondary infections. When ocular involvement is seen, it is very important to get like ophthalmology consultation as soon as possible, due to the risk of keratitis and vision loss. And for this, you can do lubricants, topical antibiotics, and topical antivirals as well. So when should antiviral therapy be considered? So usually antiviral therapy should be considered when there's severe disease, when you have ocular, oral, or genital involvement in immunocompromised patients, children under the age of 8, pregnant or breastfeeding individuals, or severe skin disease such as atopic dermatitis. The preferred agent for severe diseases are tecovirimat. We'll get into the different antivirals involved that we can be used. So one of the agents is cidofovir. It has a broad antiviral activity and is FDA approved for CMV retinitis. So data in monkeypox is limited and nephrotoxicity is a major concern. It is generally reserved for severe cases under expanded access. The next agent is brincidofovir. It is FDA approved in 2021 for smallpox. It has been used in CMV, adeno, orthopox virus infections in the past. So its use in monkeypox data still is limited, and some side effects seen with this is elevated liver enzymes were reported in some UK case series, limiting widespread use. And one of the other agents is tecovirimat. It was FDA approved in 2018. The way this drug works, it inhibits the viral envelope protein, preventing viral egress and spread. It is FDA approved for smallpox and available for monkeypox under expanded access protocols. It is currently considered the first line therapy for severe or high risk patients. So Vaccinia immune globulin IV is approved for complications of vaccinia vaccination and may be used as an adjunctive therapy in severe orthopoxis virus infections. But enroll in monkeypox is used as an adjunctive therapy for severe disease complications. So prior smallpox vaccinations do provide about 85% protection. There are two vaccines available, such as the ACAM 2000. it's a higher adverse event risk. And the other vaccine that is out there is the Neos. It is a non-replicating. It is safer, including for immunocompromised patients. So in the 2022 outbreak, the Neos has become the primary vaccine used. So when do we treat patients who have been potentially exposed or after being exposed? So post-exposure prophylaxis it is best within 4 days of exposure to prevent the disease, and maybe up to 14 days may reduce severity. And for pre-exposure prophylaxis, it is recommended who work for patients who work in like healthcare workers or those who are like in labs. So contact tracing, so contacts should monitor symptoms for at least like 21 days. Isolation continues until the complete lesion resolution, and waste from is treated as a category A infectious material, and those such as like the pet rodents exposed should be quarantined as well. Here is just a diagram emphasizing the PPE, how the collection of the swabs are done for PCR, and then also the treatment options that we went over as well, and also the vaccinations. So, some current trends and future directions. So, with the 2022 outbreak, there's been disproportionately affected young men, many identifying as men who have sex with men. They have close, intimate contact was a major driver, and public health priorities included like ring vaccination, early case identification, avoiding stigma, monitoring for like new reservoirs outside Africa as well. So with this 2022 outbreak, it remains like essential for us to do long-term surveillance. So that is the end of the presentation.
Okay, great. It was um, it was a great topic, and you did an excellent job. Like Anja was saying, the key is first thing is we have to be making sure that diagnosing the monkeypox. History taking is very important. And then the classic presentation, it can be variable, and the pictures, the all the pictures that you put very, very helpful, because when you look at the lesion, you should be able to, you know, think about monkeypox and diagnose. And sometimes we may not get the sexual history from the patient upfront, only when you think about it and then you question, they may be revealing that. And the treatment for the Tecovirimat is we have used it at the facility, at Broward. Each time, if you need to use it, you have to. There is a process. You have to get it from the state health department. So it's usually a multidisciplinary approach. We need help from infection control, state health department. Pharmacy has to help us also. There are some paperwork that we have to fill in, and only for certain patients it is indicated, immunocompromised patients and all. So anyway, so it was excellent job, and um, thank you everyone for joining.
Thank you, Dr. Prabha.
Okay.